Good afternoon, and welcome to the RDAR Spring Seminar Series. I'm Lisa Crockett. I'm a faculty member at UNL, and it's my great pleasure to introduce our speaker today, Dr. Julia Soulakova. Dr. Soulakova is a biostatistician with an interdisciplinary program of research focused primarily on tobacco use cessation and the quality of cessation-related healthcare among diverse ethnic and racial minority groups. Her work is distinctive because she integrates biostatistics, survey methodology, and tobacco use, and she applies and develops new cutting-edge statistical methods to answer questions related to tobacco use cessation and healthcare. Her program encompasses a broad array of collaboration of diverse populations beyond racial and ethnic minority groups, and she's established a wealth of interdisciplinary programs to inform that research. And collaborations, I should say. Her work appears in both statistical and health-related journals, and she's an active member of the American Statistical Association and the Society for Research on Nicotine and Tobacco. Dr. Soulakova received her doctorate in statistics from the University of Pittsburgh and was immediately recruited to UNL, where she was an assistant professor and associate professor in the Department of Statistics. She's currently a professor of medicine in population health sciences at the University of Central Florida. And it is a great pleasure to have her back at UNL, even virtually, or at least virtually, for this presentation. The title of her talk is Racial Ethnic Disparities in Healthcare for Smoking Cessation Among U.S. Adults. Please join me in welcoming Dr. Soulakova.
Thank you, Lisa, for the introduction. There is my email address at the bottom of this slide. So if you have any questions or if you want to reach me later on, please feel free. And I'd like to acknowledge my collaborators, Lisa Crockett, Trung Ha, Yujao May, and Carolyn Rice-Guzman. And today I'd like to talk about 4 different topics, and I'll start with the progress that has been made in smoking cessation prevalence and cessation in general in the United States, and talk about racial and ethnic disparities. So smoking prevalence did decline drastically in the United States. It was 42.4% in 1965, and it was 12.5% in 2020. However, the declines were not uniform across racial ethnic groups. Here you can see 2 graphs. On the left, the graph is for men, and on the right, it's for women. And these are the trends in smoking prevalence in the period from 1990-92 to 2015-16. And each graph depicts the trends for 5 racial ethnic groups. Right away, we see that for both men and women, there are overall declining trends. The lowest smoking prevalence corresponds to non-Hispanic Asian adults, and you can see that plots in light blue, the lower curves in both cases for men and women, and the second lowest corresponds to Hispanic, and you can see these plots in light green. Looking at the top curves that are in violet purplish color, these curves correspond to non-Hispanic American Indian and Alaska Natives. So consistently, smoking prevalence was the highest among this population. Also, if you take a look at the period, like within a few years prior to 2015-16, you can see that for men, smoking prevalence is somewhat constant, and for women, there is an upward trend in smoking prevalence. So just keep it in mind. I'm going to come back to that. And then the patterns are different with respect to second highest when we talk about men and women. So for men, you can see the second highest smoking prevalence corresponds to non-Hispanic, Black, and African American adults. But among women, second highest prevalence corresponds to non-Hispanic white women. And these trends continue to 2020. In another study, it was estimated that there were significant linear decreases observed when smoking prevalence was compared in 2011 to 2020. So smoking prevalence decreased among non-Hispanic white adults, non-Hispanic Black adults, Hispanic and non-Hispanic Asian adults. While the prevalence was lower in 2020 than it was in 2011 among non-Hispanic American Indian and Alaska Natives, the difference was not statistically significant. So recall that circled areas that I showed on the previous plots. So unfortunately, within this population, there was no significant difference in smoking prevalence. And there are many reasons behind these racial ethnic disparities, and some of them are already understood, but in general, I would say that they have not been well addressed in the literature. So it is believed that primarily racial ethnic disparities that we observe in smoking behaviors are due to disparities in socioeconomic factors. For example, greater educational attainment is associated with lower smoking prevalence across all racial ethnic groups. And a recent study, and you can see the citation on in the bottom of the slide, showed that in part, the disparities that we observe with respect to race ethnicity are actually due to the differences in educational attainment. Likewise, the disparities may be due to other related factors. And today I'm going to talk more about access to healthcare for smoking prevention and cessation, as well as utilization of this healthcare for smoking prevention and cessation. So finishing this part of the talk, key points. While there have been considerable reductions in smoking prevalence overall over the past decades in the United States, these reductions were not uniform across race ethnicity. And it is important to control for socioeconomic factors when we try to evaluate racial ethnic disparities in smoking behaviors or tobacco use behaviors in general. And now I want to jump to somewhat a different topic and just talk about healthcare for smoking cessation that's currently offered in the US. And I'll consider the primary care settings where usually a patient, when the patient comes to see any healthcare provider, is asked about current use of cigarettes or any other tobacco products. And if, based on this assessment, it is determined that the patient uses cigarettes or other tobacco products, then the healthcare provider offers a brief counseling and or referral to a tobacco program, to a tobacco treatment program to the patient. The initial stage of any tobacco treatment program is to assess whether the patient is ready to quit. If it's determined that the patient is ready to quit, then several strategies are recommended. And these strategies could be separated into two major types. First type is pharmacological aids, and the second one is behavioral aids. So when we are talking about pharmacological aids, we mean nicotine replacement therapy that comes as in the form of patches, gum, lozenges, spray, or inhaler. And by the way, you can purchase over-the-counter some of these products, such as patch, gum, or lozenge. However, the spray and inhaler do require a prescription. In addition, there are non-nicotine medications that are bupropion and varenicline, and both require a prescription. The major type of behavioral aid is counseling. And counseling could have many different forms. It could be individual, it could be group, it could be a long-term or short-term, and it could be provided in person, by phone, or via internet. Also, the general recommendation is to advise patients who want to quit smoking to use combination therapy, so to combine both pharmacological and behavioral aids. And this recommendation is based on literature. So, for example, you can see an estimate reported here based on a review of 114 publications. It was determined that use of such combined therapy increases the likelihood of smoking cessation by 82% when compared to minimal intervention or usual care. All these cessation aids that I mentioned are evidence-based, and they are recommended for smoking cessation. But there is a question: how commonly are these aids actually used in practice? Here you can see the overall trends in the rate of use of at least one cessation aid in the years from 2000 all the way to 2015. There was a significant increase from 2000 to 2005. You can see the rate of use increased from 22% to 29%. However, in the period from 2010 to 2015, there was no significant increase in the rate of use of cessation aids. Also, if we look at individual types of cessation aids used, and here I report results of one of our earlier studies where we considered serious quit attempts that lasted for 1 day or longer, and these attempts occurred in the period from 2007 to 2011, you can see that the majority of adults, 72%, tried to quit with no aids. You can also see that pharmacological aids only were used in 22% of cases, behavioral aids only were used in 2% of cases, and the combination therapy that I mentioned before was used in 4% of cases. And these percentages slightly changed toward 2014-2015, but you can see that the combination therapy was used only in 5% of cases, and behavioral aids only were used in 2% of cases. Next, let me talk about what's known about in terms of racial ethnic disparities in use of cessation aids. And I want to mention that when I summarize the results in the literature, unfortunately, there are differences in the studied populations. So on the slides, I put in parentheses a note about what type of smoking cessation duration was considered in each study. In this study, we considered quit attempts that occurred in 2007 to 2010, and we looked at use of pharmacological aids among adults who completely quit smoking at the time of assessment. We controlled for many factors, including socio-demographic characteristics, and you can see that we included some socioeconomic related factors, such as highest level of education and employment status, and there were some additional factors. So after controlling for all these factors, race ethnicity still was a significant attribute of use of pharmacological aids when we compared use of pharmacological aids versus use of no aids at all. And on this slide, you can see the corresponding odds ratios. So the odds of use of any pharmacological aid versus no aids were significantly lower among non-Hispanic Black, African American, and Hispanic adults relative to non-Hispanic white adults. And these results were adjusted for multiplicity, and you can see the corresponding p-values in the right column. Okay, and the next study I want to mention very briefly is the study where we considered quit attempts occurring in the period from 2007 to 2015, and we looked at the benefits of social support as well as use of behavioral aids during the last quit attempt. And here we considered all adults who quit smoking and remained abstinent from smoking for at least 7 days. And I will just mention the final conclusion. The graph here suggests that overall behavioral aids were more commonly used among non-Hispanic white adults, but you can also see that the percentages are pretty lower across all racial ethnic groups. And our conclusion was that after controlling for socio-demographic characteristics and year of cessation, the racial ethnic disparities in use of behavioral aids were not statistically significant. Okay, another study considered quit attempts in 2013-2015, and we looked at use of aids overall as well as use of aids by the type of aid, so pharmacological versus behavioral. And I also note that they considered serious quit attempts that lasted longer than one day and included adults who had a relapse and those adults who completely stopped smoking. And these analyses were not adjusted for the other factors, so you can see some discrepancy, but they are not major discrepancies relative to the results that I presented earlier. So these are the rates of use of any aid, and the authors concluded that relative to non-Hispanic white, non-Hispanic Asian, and Hispanic adults utilized any cessation aid less commonly. So the corresponding prevalence of use of any aid was lower among these populations. And these are the percentages for use of pharmacological aids and use of behavioral aids. And again, the conclusion was that non-Hispanic Asian adults and Hispanic adults were less likely to utilize pharmacological aids during the acute attempts relative to non-Hispanic white adults. But with respect to behavioral aids, authors concluded that they were similar, the rates of utilization behavioral aids. And also note that there is a common limitation that some racial ethnic groups are not included in the analysis. Like in this case, we can see that use of behavioral aids was not considered with respect to non-Hispanic Asian adults due to limitations related to sample size for this group. To summarize this part of the talk, there is evidence-based healthcare for smoking cessation. Use of pharmacological aids is less common among communities of color relative to non-Hispanic white adults. Behavioral aids and combined therapy are underutilized across all racial ethnic groups. And the final part of my talk is about a role of healthcare insurance coverage in reducing racial and ethnic disparities in smoking behaviors. And the key question I want to try to answer today is having a health insurance coverage critical for smoking prevention and cessation? And before going to the literature, I want to try to debate on this topic. So let's think about some reasons why we might think that having a health insurance coverage is not important in terms of smoking prevention and cessation. Well, one can argue that the progress has been made toward reducing smoking prevalence. And one of the reasons why it happened is because the public overall is well aware about the harmful effect of smoking and use of other tobacco products. Another reason one can state here is that currently there are many federal and state cessation resources that are free of charge for adults who want to quit smoking. For example, in the state of Florida, all adults who want to quit smoking are offered both nicotine replacement therapy and counseling. However, one could come up with several reasons why having a health insurance coverage is still important in terms of smoking prevention and cessation. And one argument could be that interactions with healthcare providers that are more common among patients with a health insurance coverage. So these interactions raise additional awareness about harmful effect of smoking. So these assessments of current tobacco use, including smoking that I mentioned earlier, they actually help remind adults who use tobacco or who use cigarettes specifically about harmful effects. In addition, some pharmacological cessation aids actually require a prescription, as I mentioned before. So if we think more about that, who really needs a prescription? Usually these are the adults who are more nicotine, who have higher nicotine dependence. And for these adults, we would argue that having a health insurance coverage that could cover smoking cessation medication would be a huge benefit. Okay, and let's see what current knowledge says. Actually, all arguments that I just mentioned, they are all important and they all have some logic behind them. The overall conclusion is that health insurance coverage plays an important role in smoking prevention and cessation in the United States. And having a health insurance coverage is associated with reduced smoking prevalence overall in the United States. However, there are disparities in smoking prevalence by insurance type. Specifically, smoking prevalence is highest among adults with Medicaid coverage and lowest among adults with private coverage. And next, I want to present some results from our most recent study where we looked at smoking prevalence by race, ethnicity, and type of coverage. And we considered 3 types of health insurance coverage: private, Medicare, and Medicaid. And at the beginning, let's just look at results of analysis that ignored all other factors. And before I show the results, I will just say a few words. So we considered adults, and you can see the distribution by age and sex presented here. And this is the composition with respect to race, ethnicity. Note that we had the lowest sample count or sample size corresponding to the non-Hispanic, Hawaiian, and Pacific Islander adult group. And we had only 103 adults in this group, or data for 103 adults. And therefore, this group, unfortunately, was not included in the comparisons that I'm going to show you next. So let's look at private coverage. You can see the percentages, and these percentages correspond to smoking prevalence for adults who have private coverage and adults who don't have private coverage. So this is the column for adults who have private coverage, and this is for adults who have no private coverage within each racial ethnic group. So what can we see? If you just look at percentages and try to compare them, I think you agree that having private coverage is associated consistently with reduced smoking prevalence. But the differences in smoking prevalence are significant only within non-Hispanic Black African American group and non-Hispanic white group. Somewhat a similar pattern we can see with respect to having a Medicare coverage. Again, usually having that type of coverage is associated with smaller smoking prevalence, but the results are significant only among non-Hispanic white adults. However, the picture changes completely when we are talking about adults, or when we compare adults who have Medicaid and adults who don't have Medicaid. So you can see that not having Medicaid is associated with lower smoking prevalence relative to having Medicaid. And results are significantly different within non-Hispanic Black African American group and within non-Hispanic white group. Again, these results that I just depicted, that I just discussed, were not adjusted for any additional factors. So let's see what we can observe based on the data after we control for additional covariates. And these are some of the factors that we considered, that we adjusted for. So we included age, biological sex, marital status, highest level of education, annual family income, disability status, and several other factors. And due to the sample size limitations, again, we could not consider all racial ethnic groups. So we had to limit the analysis only to Hispanic, non-Hispanic, Black, African American, and non-Hispanic white adults. The overall conclusion was that the racial ethnic disparities in smoking prevalence differed significantly between adults with private coverage and no private coverage. And here you can see the odds ratio of smoking prevalence when adults with private coverage were compared to adults with no private coverage. Within Hispanic group, there were no differences in smoking prevalence. So you can see the simultaneous 95% confidence interval for the odds ratio in the right column. Sorry. Okay, I'll try not to touch the screen. Okay. And similarly, there was no significant difference in smoking prevalence associated with having private coverage or not having private coverage among non-Hispanic, Black, African American adults. We did observe a difference within non-Hispanic white group only. Additional conclusions that we made, but I'm not going to present the detailed results here, that racial ethnic disparities in smoking prevalence were similar when adults with Medicare coverage were compared to adults with no Medicare coverage, and similarly when adults with Medicaid coverage were compared to adults with no Medicaid coverage. So basically, other factors that we considered in the model helped explain the variation, and race ethnicity was no longer significant, or I should say the interaction between race ethnicity and having the corresponding health insurance coverage was not significant in the model. And this is the conclusion that we made. After adjusting for other factors, having private coverage was significantly associated with lower smoking prevalence only among non-Hispanic white adults. Thus, adults of color appeared to benefit less in terms of reduced smoking prevalence than non-Hispanic white adults from having private coverage. And to conclude this part, these are the key points. Health insurance coverage is important for smoking prevention and cessation. There are disparities in smoking by type of coverage. Among private coverage beneficiaries, only non-Hispanic white adults seem to benefit in terms of reduced smoking cessation. And unfortunately, we did not observe these benefits with respect to other racial ethnic groups considered in our study. Also, I'd like to note that there is a lack of population-based research addressing use of healthcare for smoking cessation among some communities of color. So usually, studies limit to non-Hispanic Black, non-Hispanic white, and Hispanic adults, and very limited basically no results available with respect to non-Hispanic American, Indian, and Alaska Native adults. And this is very critical because the smoking prevalence and tobacco use in general is the highest within this population. And I'd like to finish my talk with the following quote by Min Young Guy. Min Young was the recipient of Society for Research on Nicotine and Tobacco Pebbles Fagan Award this year, and she got that award in March at the SRNT annual meeting. We had a discussion with respect to smoking and tobacco use in general among Black communities. And this is the quote by Min Young Guy. If we want Black adults to stop smoking, we may want to find a better way to address some of the root causes for smoking. The issue is much bigger than access to care or culturally appropriate information when we are talking about not meeting basic needs for a given population. Smoking does not occur in a vacuum, and yet we continue to study cessation, quitting, as if it does. Maybe it's time to do something different. And I think this is a very empowering message, and it can be expanded to include other historically underserved communities in the United States. And this completes my talk.